From Wana Brands, welcome to Enhance Your Life. I'm your host, Jonathan Small, and each week I talk to people from all sorts of professions and backgrounds about how cannabis has enhanced their lives and how this healing plant can enrich your life too.
Well, hey, everybody. Welcome to the Enhance Your Life podcast. My name is John Small, and I'm very excited to introduce you to our guest today, Dr. Jordan Tishler. And Dr. Tishler is president of the Association of Cannabinoid Specialists and Internists at inhaleMD. He is a leading expert in the field of medical cannabis therapeutics. Dr. Tishler graduated from both Harvard College and Harvard Medical School and is faculty at both Brigham and Women's Hospital and Harvard Medical School. As an emergency room physician, he has treated countless patients suffering from drug and alcohol addictions. We have lots to talk about. Dr. Tishler, welcome to the show.
Well, thank you for having me. Pleasure to be here.
So first, I'd love to start with an origin story about why you started inhaleMD and why this Harvard-trained, incredibly impressive doctor believes in cannabis, which we know has a bit of a stigma in that sort of mainstream medical community.
Absolutely. I often say to people, as you've sort of alluded, that my background is as conventional as it gets. Certainly, being through Harvard 3 times over sort of makes me sound kind of dull, actually, as I think about it. But anyway, the joke is if you do Harvard 3 times over, then you're called preparation age. So there you go.
Perfect.
So I trained in internal medicine. I actually trained to be a primary care doctor of all things, and then didn't do that. I went off and did emergency medicine instead. I was the guy in the residency program who was trading away all of my oncology time for emergency room time because I just loved the emergency room.
What was it about? Just the excitement of it?
I don't know that it was excitement.
I guess I shouldn't mean that, it's so happy to see all these injured people, but like maybe the sort of unpredictability of it.
There's a very intense immediacy of it. And not everybody, but a large fraction of the people that you see are sort of moderately to severely sick. And so one thing you can say is they really need you,
Yeah.
And there's something lovely about that. And when you get good at something, then you can feel that your talents are being put to good use.
Yep.
And in fact, that is exactly how I got into emergency medicine. It's exactly how I got out of it also. So I practiced in a small community called East Boston, which was largely underserved immigrant population. I did that for about 5 years. And then I went to another underserved population, which is the United States veterans. So I ended up working for the VA for 15 years in the emergency department. And over that 15 years, I sort of felt like I had sort of seen everything and done everything. And not only that, but I had taught so many people to know and be able to do all the things that I could do. Then at some point I started to say, all right, look, I think I've kind of done the challenges that are here and passed on the knowledge that I have. So what else is new?
Yeah.
And it was somewhere around the time that those feelings were evolving back in 2011, 2012, that Massachusetts started talking about medical cannabis and this ballot initiative to legalize it. And I sort of thought, I had one of those aha moments. I said, I've seen so many veterans who have been really harmed by all kinds of substances. And frankly speaking, when we're talking about substances, on that top 10 list, 1 through 9 is alcohol, right? And then down at the bottom, maybe there were some opioids and benzos, but really alcohol.
Right.
All right, look, alcohol's really legal. Everybody can get it. And yet it's like really destroying these people's lives. And now here we have this cannabis thing that people say maybe could be useful as a medicine. And I've never seen anybody sick from it. So how can I say, oh, cannabis is bad when I'm not seeing anybody get sick compared to these things that are kind of freely available? It turns out that cannabis can make you sick, but it's not generally the kind of stuff that shows up in an emergency department most of the time, and that's good. But really what happened was I sort of said, okay, if this is coming and I'm not seeing people sick from it, then I should learn something about it, right? How am I going to learn something about it? Well, I went to PubMed, which if people don't know is sort of the government-funded national database of research science. And you put in the word cannabis, It's kind of like Google, but for science, but more intense than Google Scholar, which is sort of halfway in between. So back then, people would say, oh, I don't know about cannabis. In fact, Mrs. Clinton said when she was campaigning, I don't know about cannabis because there's no data on it.
Yeah.
And I said, oh, well, okay. And then I went to PubMed and you put in the word cannabis and you get back 25,000 studies. 25,000.
Wow.
Like, wait a minute, what do you mean there's no data? If you go and you put alcohol in back then, you would get 5,000 studies. So how can there be 5 times as much data for cannabis as for alcohol? And everyone's saying, oh, we don't know anything. All right. So it turns out that the statement, there's no data, is a political issue. It's a way of sidestepping things. But I had to kind of figure out on my own, because nobody was there to guide me, how am I going to ingest some portion of the 25,000 studies and make sure that I'm reading the right ones and then synthesizing this into something that's usable, in a clinical practice. And the answer I came up with at the time was there was no good answer, and I was just going to have to read a whole lot of studies, and that's what I did. I really slogged my way through the literature over a several year period of time while I was still working for the VA. There's a process. It's not like you just pick 25,000 random studies. You start with one, you read it, you understand it, then you start looking at what are the references and you kind of follow the breadcrumbs, and it makes a little bit more sense. And what I came away with after this sort of several year process was cannabis is a medicine. Cannabis is a medicine in that it can be helpful. It's a medicine in that it has to be applied to the right situations and in the right people. It has to be applied with attention to dose. It has to be applied with thoughts to its risks, not just its benefits. And in short, it's kind of not that different from any other medication, except somehow in our society, we treat it as completely different. Either we treat it as though it were plutonium and terribly, terribly dangerous, or we want to pass it off as completely harmless. And the reality of the situation, like every medicine, any substance that does something, it can do something good, and it's likely to also be able to do things that are not so good. And so you have to be mindful and thoughtful about how you use it. Oh, okay, that sounds like medicine. I know how to do that.
Right.
And then I sort of looked around in my universe and said, all right, now I know this stuff and other people don't seem to know it. So maybe I need to figure out a way to bring this knowledge to patients in a clinically useful fashion. As you can imagine, the VA sort of looked at me like with 3 heads, right? I mean, they're like, what are you talking about? It's illegal, it's illegal, it's illegal. And I'm saying, okay, fine. That actually had to go all the way up the chain to the attorneys in DC, because what the really question was while I was working for them, was there any reason that they should or could object to my starting my private practice? And ultimately the decision was whatever I did on my own time was fine. So that was great. And then I looked at the major medical institutions like the Brigham and the Mass General, where I'm faculty, and they're all federally funded, right? So little known law from the Fed says that if you break a federal law in one area, they can not only punish you for that, but they can punish you kind of across the board by taking away all of your funding, all federal funding. These hospitals run with billions of dollars worth of federal funding, and that could overnight go down to zero.
Right.
So you can be sure that those hospitals,
it's not worth the risk.
Yeah, they just can't stick their neck out that far, because if they did get socked, look at how many hundreds of thousands of patient visits would go up in smoke every year, not just from the point of view of getting paid for it, but in terms of those people need the care, right? And they, it's not like you can, if you're the big hospital in town, it's not like you can say, oh, well, you can just go across the street to something else, right? So they have a big responsibility there, and I can't fault them for their hesitance. So I started my private practice. I often say, look, I wasn't really looking to start a private practice, but this was the vehicle by which I could take care of patients using this medicine, and then also be able to go back to my colleagues in the various institutions and teach them about this, so that we could work out this kind of consulting or specialist relationship where I became part of the patient's care team, and we had good communication between myself and the patient and all of their other doctors and providers. And that's a really great model that's worked very well.
And your practice is in Massachusetts, right?
Yes, that is correct.
Do all your patients come from Massachusetts?
No, I do a fair bit of telemedicine. Actually, I do almost 100% telemedicine, even in Massachusetts at this point. And that was brought about by COVID. But frankly, even now, as COVID may, we hope, be winding down, what I'm finding is that telemedicine brings a lot of advantages in terms of being able to see people in their home environment where they're relaxed and also not have to schlep them into town and have them worrying about parking and traffic and all that stuff. So I suspect the future holds some sort of a hybrid model where maybe we'll be meeting in person for the first visit and then maybe meeting virtually on subsequent visits. That's sort of still up in the air because there's a fair amount of regulation around that that's very much in flux. But so I take care of patients all over the place. So, I mean, I certainly take care of patients in Massachusetts, but also in neighboring states like New Hampshire, Vermont, and Rhode Island. But then I also take care of people worldwide. So I've taken care of people in places like California, where it's very easy to get cannabis, but very hard to get any knowledgeable cannabis advice. And I take care of people in states where they don't yet have legal cannabis, like South Carolina, North Carolina, Georgia. I'm also working hard to help those states kind of get with a program, so to speak. And sort of to that end, I should mention that as I was developing my practice and my knowledge base, I started to realize, partially because I was getting taunted by some colleagues, that very few doctors knew this information, but even fewer of them were practicing medicine the way I think medicine should ethically be practiced. And that in part because of the history of the way medical got legalized in California back in the 90s, there are all these card mills where you can go and for a couple $100, some doctor will give you a card in your state, but that's all you get. You don't actually get any guidance or follow-up or doctoring, right? You get just this sort of get out of jail free card. And while it's great to have that card, as we talked about a few moments ago, no medicine is really useful if you're just kind of throwing darts at the wall. You need somebody who knows how to use it, what the pitfalls are, how to avoid those pitfalls, and also somebody who's available when you have questions and follows up with you on a regular basis. And those are the things I do. So I started an organization. I started this Association of Cannabinoid Specialists that you mentioned. It's a not-for-profit, and it is now international. And the goal there was really twofold. One was to educate docs and other clinicians so that they can take proper care of their patients and do it ethically. And then the second is to work on the political side or on the advocacy side to try and make the systems work better for patients and their clinicians so that patients actually get the medicine that they need as opposed to whatever the bud tender sort of wants to sell to them that day.
It's so important what you do because you're right. I'm here in California and it's so readily available. But I have, for example, I have generalized anxiety disorder. And when I go into a dispensary and I say, hey, what would be a good product for generalized anxiety disorder? I'm trusting a bud tender who, I love bud tenders, but they're nice people, but they don't have an expertise.
Great people.
Yeah.
Right. I mean, they're not doctors.
Yeah.
And people often say, well, what does it take to train the bud tenders better? And I say, well, send them to medical school. I mean, there isn't a shortcut there. I don't think you can go from being a Starbucks barista level employee to being a competent medical provider, with just kind of like a few hours of coursework. It just doesn't work.
So who are your patients?
Good question. I think that, and just, put a pin in something, let's circle back to anxiety disorder in a few minutes. But who are my patients? My patients are not who you'd think, right? I mean, so, the whole California thing is like, wink, wink, I have some anxiety, doc,
Yeah.
And I do have patients with anxiety, but those patients are not like, your sort of 20-year-old who says, yeah, I'm having some anxiety because I have to take a test next week.
Right.
The people I'm taking care of generally are older. The majority of my patients are sort of 60, 70 and older. My eldest to date was 104. I've got, unfortunately, she passed away, but wow. I have a bunch of 90-year-olds and they're doing great. So that's kind of the big group. And those people tend to have things like arthritis, pain, cancer, but also anxiety and insomnia. Insomnia is huge. I mean, it's number 2 after pain in general. And I think it's the thing that cannabis treats the best of all. So it can be really successful in an area where, frankly, we don't have a lot of conventional meds that are very good. And then there's a second group that's kind of middle-aged folks who may be developing some arthritis, but unfortunately, generally speaking, they're the ones who are getting cancer. And so we can address a number of cancer-related things using cannabis, whether it's sort of nausea and vomiting from the chemo, or pain from the chemo, or pain from the cancer, anxiety from the diagnosis, insomnia as a result of that, all sorts of symptoms that kind of come along with the big C word there. And then I have a smattering of younger people who, as I mentioned, have anxiety, but they have really refractory anxiety. I have some folks with autism or Asperger's spectrum disorder, and then a smattering of people with MS and ALS and stuff like that kind of span the age groups. So that pretty much describes my folks.
Yeah. So when you take a patient, or when a patient finds you, what's the process? Do you have a consultation and then you make suggestions, or can you take me through a little bit?
It's very specific. So let me describe. So when I started, one thing that was interesting is that most of my patients came to me on their own. They were either, their doctor said, I don't know anything about it, or they were just frankly afraid that their doctor would sort of chastise them, so they didn't ask. So they would find me on the web, or from listening to podcasts like this thing, or something like that.
Yep.
And while that was a good beginning, my goal was always to sort of help normalize this in a certain way, so that what I really wanted was to get to the place where doctors were referring their patients to me. Mm-hmm. And I'm happy to say that worked really well. That I spent a lot of time and effort going to the hospitals and speaking to my colleagues and trying to convince them that I hadn't lost my mind, and that in fact, here were the data. And,
what was their reservation? Listen, I have a family member, a Harvard educated doctor in Nashville now, who is not particularly pro cannabis, but and I can't talk to him because doctors, as you know, they have a bit of ego.
Really?
Yeah, exactly. So what is the pushback you get from doctors?
I think there are kind of three issues. First, there are some people who just don't want to hear it, right? I mean, they were brought up to be generally fairly conservative, and they were taught that it's bad for you or that it's morally wrong. And those people, I think, we're just never going to convince.
Right.
And I don't know that is particularly true of doctors compared to other people. It's just that, of course, the doctors are the group that we want to most convince.
Yep.
And I suppose politicians fall in that category also. And quite frankly, thankfully, I think that that's a fairly small minority of the doctors who are hesitant. The larger groups, I think, fall into the category of they don't know anything about it, right? I mean, they know that they don't know. They also know that they're not particularly interested in delving into it the way I was. And so it's not so much, I think, that they're saying, no, cannabis is bad for you. It's more like, I'm just not getting into it. And I can understand where they're coming from. And that also leads and overlaps with the third group, which is the doctors who might be generally pro the concept of it's being helpful. But frankly, medicine in this country is so overprogrammed, meaning doctors are told they have to see a patient every 10 minutes.
Yeah.
And in your 10-minute visit, you need to do a breast exam, a pelvic exam, talk to them about smoking cessation, blood pressure, cholesterol, bicycle helmets, car seat belts, the list of things that you're supposed to cram into a 10-minute visit. Oh, don't forget that the patient has to get into the room and get undressed, right? I mean,
right.
All that stuff in 10 minutes, it doesn't work. And we're seeing this as a problem in American medicine across the board. But you can imagine from the physician's point of view saying, crap, how am I going to fit anything more like cannabis stuff into my little tiny 10-minute slot? And the answer is, quite frankly, they can't. And it's unreasonable of us as a society to think that they could, which is why I developed this idea of the cannabis specialist as somebody who, like an endocrinologist or a cardiologist, focuses just on this little piece, perhaps has a longer visit span to spend on just this little issue. And then we work hand in hand with the primary care or neurologists or other doctors to synthesize that into something that works well for the patient. And that, I think, is really the only viable model. I mean, by contrast, for example, getting back to your question about the process, My initial visit, my first visit with a patient is an hour long.
Wow.
And I don't have to talk about seatbelts and breast exams, right? I'm just talking about what's going on with them now. What are the problems? How do we understand them? And then what do we know about cannabis and how do we make cannabis work for solving some of these problems? And that takes up a full hour. I have a packet, which has now been virtualized, of all of the information that patients need to know. And literally we go through this online page by page, and I tell people about the different modes of use, like inhalation versus oral. And we talk about tinctures and topicals. And I talk about, this is good for this kind of a problem. This is good for that kind of a problem. These things are not good for anything, like the topicals and tinctures. That's overstating things, but
well, that is interesting. I did read that article on your website about tinctures not being, but anyway, we'll get back to that.
Yeah, let's come back to that. And so all of that kind of information hones down into okay, what are we going to do for you? Then we get into the risks and side effects and things you need to know. And then we get into the administrative things of here's how you get your card. And then sort of at the very end, we come back to this is the plan and this is how you start it. And this is how you advance it. And this is how you reach me. And please do reach me. And I'm amazed at how many patients do not ever reach out to me. And then I see them back. That's the other thing, like most states will allow you to write a cannabis card for a year. There are even some states out there that now I think foolishly will allow you to write a multi-year cannabis card. And I'm just thinking, look, nobody would put anybody, especially for the first time, on a new medicine of any other sort and say, see you around in a year. Right. So I see everybody every 6 months without fail. And more than that, as things come up. And so that may be, I give people my email address. I tell them, if you have any questions or concerns, email me. I'm really good at getting back to people by email. I'm sort of a little bit more of a digital native in that way. Yeah. And so I just keep as close a tab on how things are going with my patients as they will let me. What's always kind of interesting to me and somewhat disappointing is when 6 months go by and I see them at their next visit and they say, well, these things happened or these things went wrong.
And they didn't tell you.
I'm thinking, why didn't you email me? You have my email. We could have fixed this 3-4 months ago and you'd be better off. Then now we're going to fix it today. So
why do you think they don't call you? Is it because they're embarrassed or because they, or because they just, this thing didn't work. I don't like it, whatever. Or like maybe they had a bad experience. They got a little too high and they're like, I don't like cannabis, whatever it is.
All of those things, hopefully not the embarrassed thing, but certainly the bad experience or didn't work, or I got sidetracked with other things. Those do come up. But to me anyway, those are all the exact times that you would want to reach out to me, because most problems turn out to be fairly simple and easily fixed. But I also think that there's an element of it, which is that between some people not wanting to bother their busy doctor and some people feeling frustrated that they can't reach their other doctors, they probably assume that it's hard to reach me, which it really isn't. But I think that may play a role too. And I just keep begging people to reach out, and hopefully at some point it sinks in.
So the message is, do not just call you every 6 months, like check in.
Yeah, absolutely. I mean, I really try to make it as easy for people as possible, which I think is in contrast to the way most American medicine is practiced. And, and this kind of gets me back to the whole idea of my private practice, which is to say that most doctors are employees and they sort of have to follow the rules that the institution sets for them. And one of the things I did when I finally decided I was going to start a practice was I said, all right, I'm going to do this my way. Right. Yeah. I'm going, if I don't have a boss, I may not make much money, which I frankly don't, but that's all right. But I'm going to set it up so I can spend an hour with people and half an hour on subsequent visits. And I'm going to set it up so if people need to pop in for an interim visit, that's okay. And in fact, I very deliberately set up our payment approach around that idea. So rather than being a strict fee for service, where it's like, you have an appointment, you pay for the appointment, you have another appointment, you pay for that. We don't do that. We have an annual subscription payment. So that means that during that year, you get those 2 visits that we talked about, plus kind of all you can eat, right? And so email, voicemail, or telephone, or a Zoom, any of that, whatever is necessary in order to keep things going in the right direction. And my hope was always that if it's prepaid like that, essentially, then there's less barrier for people availing themselves of me as a resource for them.
What do you think the most misunderstood thing is about cannabis from your patients that come in?
There's so many, it's hard to decide which one is which.
Top 3.
I hear a lot from patients, doc, give me the cannabis that won't make me high. That launches me into a discussion of, number one, that cannabis, if it's working, is always going to cause some amount of intoxication, that we can think of the intoxication as a side effect. And like every medicine, cannabis has side effects. And that our goal is to find the dose where we get the benefit that we need while minimizing those side effects.
Right.
And I think this really gets into a whole big division, if you will, between medical and recreational. In medicine, we want to find the smallest amount we need to get the benefit and then stop. And what we want is something that is, quite frankly, boring, right?
Mm-hmm.
I take it, it works, I don't think about it.
Yeah.
I take it, it works, I don't think about it. It's dull and repeatable and reliable, and it just does its thing. Recreational is very different. Recreational is like, what's new, what's exciting, how much can I take, what will the experience
recreational
be like?
Is all about how much more THC can I have.
Right, exactly. And you know, I'm okay with that up to a point. There is a point where there's enough THC that you can actually start to develop some problems. But fundamentally, there's a really different approach, philosophically and practically speaking, to medical versus recreational. And I think that's something that most people haven't wrapped their heads around adequately, in particular because the cannabis industry is so focused on recreational, even in the medical setting, and selling more and more weed, that the idea of less is more just, it doesn't fly very well, and it's not part of the current conversation adequately.
Do you use cannabis in your own life?
That's a question that I think it's fair to ask, but I'm going to decline to answer just on professional grounds.
I understand. Well, this has been fascinating. I want to bring you back on. I have like a list of questions here, and I want to be mindful of your time. You are a doctor and probably very busy, but it's called inhaleMD. If people want to find out more about your services, about your work, where should they go?
They should go to inhalemd.com, which is my website. And, you know, obviously it talks about what we do for people, but I think the more interesting part is that there's a whole blog section that has over 200 articles written for normal, ordinary people. And it covers all kinds of discussions, like various illnesses, like anxiety that we mentioned, and also sort of the risks and the benefits. So it's a really good place to start getting unbiased, accurate, data-backed advice. And then hopefully that makes people feel educated enough and confident enough to reach out to us if there are things that they would like some help with.
Terrific. Well, Dr. Jordan Tishler, thank you so much for taking the time to speak with us today.
Oh, entirely my pleasure. And if you want me back, I'm there.
Enhance Your Life is brought to you by Wana, the #1 infused product in North America. Wana's entire process is designed to deliver the same great experience time after time. They have spent years fine-tuning their recipes so that their products are delicious, consistent, and potent. For more information, head on over to wanabrands.com. That's Wana, W-A-N-A, brands.com.